previously we discussed the histological types and histological classification of breast cancer. Now molecular classification of breast cancer. According to molecular types of breast cancer, we will classify the breast cancer into 5 types: luminal A, luminal B type, triple negative or basal-like type, HER2 enriched, and normal-like type. Let's start with the luminal A breast cancer. It is hormone receptor positive. That means estrogen receptor and or progesterone receptors positive, HER2 negative. This type carries low-grade tumor, and it is the best type in its prognosis. The tumor will grow slowly if it is of luminal type A. Luminal type B, or it is called a triple positive type. Here the hormone receptors are positive, estrogen and or progesterone receptors positive, HER2 positive or HER2 negative. This type generally grows higher than or faster than luminal A type, and the prognosis is slightly worse, but it's still better prognosis than other types. A triple negative or basal-like type, here estrogen receptors, progesterone receptors are negative and HER2 negative. All 3 markers are negative. The type of breast cancer, this type is more common with BRCA1 gene mutation. This type carries aggressive prognosis. HER2 enriched, here we have estrogen receptor and estrogen receptor is negative and HER2 positive. This type carries poor or worse prognosis, but here treatment with Herceptin is useful. Normal-like breast cancer is similar to luminal A disease. Here we have hormone receptor positive, estrogen receptor and or progesterone receptors positive, HER2 negative, similar to normal-like breast cancer. Here it carries good prognosis, and but the prognosis is slightly worse than luminal A cancer. Here we have 4 types: luminal A, luminal B, HER2 new, normal breast-like, and basal-like triple negative molecular type. As you see here, the classification depends on the ER/PR status and HER2 new receptor status. In luminal A, ER and or PR are positive, HER2 negative. And this accounts for about 44% of cases, and it is the best one in its prognosis. Luminal B, triple positive type. Here ER and or PR positive, HER2 could be positive or negative. This accounts for 24% of cases, and it's slow growing, but it is slightly worse than luminal A. HER2 new enriched type, here we have ER negative, PR negative, HER2 positive. It accounts for about 11% of cases, and it is aggressive type. In normal breast-like type, ER positive, PR negative, HER2 negative. This accounts for 2%, and the tumor is slow growing. In basal-like triple negative, ER negative, PR negative, HER2 negative, this accounts for 19% of cases, and it carries an aggressive behavior. This is the percentage of each type of molecular types. Luminal A accounts for about 44%. This is luminal B. This is basal-like. Here we have HER2 enriched, and 2% only for normal like. Now, grading for breast carcinoma. How can we do microscopic grading? Because the grade has great relationship with the prognosis of breast cancer and also the treatment. We have the grading system, which is called Nottingham classification of Bloom-Richardson system. This depends on tubule formation, nuclear pleomorphism, and mitotic counts. In tubule formation, we have 3 points. We depend on the amount of tubule formation. If the tubule formation accounts for more than 75% of the tumor, then we put 1 point. We put 2 points if the tubule formation is between 10% and 75%. It is more than 10% but not more than 75%, so we put 2 points here, and we give 3 points if the tubule formation is less than 10% of the tumor. So we see here tubule formation, if it is more abundant in the tumor histologically, so this gives better prognosis, and it give low point. We give 0.1 and 1 point if the tubules are large in their number. The nuclear pleomorphism, we give 1 point if the nuclei show a minimal variation in their size and shape, and we give 2 points if the nuclei show moderate variation in their size and shape, and we give 3 points if the nuclei show marked or prominent variation in the size and shape. And then the other grading index, we depend on mitotic counts. Also, if high number of mitosis, we give 3 points, intermediate we give 2 points, and if low mitotic count we give 1 point. Then we come to a final scoring system. How can we do the scoring? We take the sum of the points we collect in the grading system, depending on the tubules, pleomorphism, and the mitotic count. If we collect 3 to 5 points, then this is grade 1. If we collect 6 to 7 points, this is grade 2, and 8 to 9 points, this is grade 3. Now the staging system for breast carcinoma. This is American Joint Committee for Cancer staging. This depends on the primary tumor and lymph node status and distant metastasis. The primary tumor, we have TIS, which include in situ carcinoma, whether ductal carcinoma in situ or lobular carcinoma in situ or Paget disease. And then we have T1, T2, T3, and T4. This depends on the size of the tumor. If it is less than equal or less than 0.1 cm, so this is T1, and so on. T2 if the tumor is more than 2 cm but not more than 5 cm, and if the tumor is more than 5 cm, so this is T3. T4, we put the tumor under the T4 if the T4 is not, we not depend on the size of the tumor. T4, regardless the size of the tumor, we put the tumor in T4 category if there is extension to the chest wall, or if there is a skin ulceration, or if it is inflammatory carcinoma, or we have both extension to chest wall or chest wall invasion and skin ulceration. And if we have inflammatory carcinoma, regardless the size, even if it is 2 cm or 1 cm, and there is extension to chest wall or skin ulceration, or it is of inflammatory carcinoma and microscopic type, so this is stage T4. Now we come to a lymph node pathological stage. Regarding the lymph node, here we have lymph node status depends whether micro or macro metastasis, the number of lymph nodes, and the site of lymph nodes that involved, whether internal mammary lymph nodes or axillary lymph nodes, and accordingly we put it under the which category of the stage of the lymph node. Now we come to the stage grouping. We did the grouping depending on the size of the tumor, PT, and the status of lymph nodes. For example, if we have a tumor of 4 cm, so this is T2, and we have 2 lymph nodes involved, this is N1. So we see here T2 N1 is equal to stage 4B. So the tumor is pathological stage 2B. Here an important point about the lymph nodes. It depends on the microscopic examination of the lymph node and not on the size of the lymph node, because the size or clinical determination of the status of lymph node is not as pathological staging, because the lymph nodes might be enlarged but they microscopically show only hyperplastic features and there is no tumor metastasis in these lymph nodes. So this not regarded as metastasis. And also there might be small size of the lymph node, but it contain a metastatic malignant tumor. So it depends on the pathological staging and not the clinical staging. Now the prognosis and the predictive factors of breast cancer. This depends on many factors, including patient's age. الtypical older age and postmenopausal women carries best prognosis than young women, especially if their age is below 35 or below 40, because in this age we put them in the category of the familial breast cancer. كل ما كانت البيشنت young age وعمرها صغير كل ما كان احتمالية طبعا under the age of 35 or age of 40 هنا احتمالية الفاميليال كانسر تكون high. Pregnancy and oral contraception. معروف pregnancy will make the tumor worse, يعني high grade and rapidly metastasize and higher stage than in non-pregnant women. Early diagnosis, we mean by this in being invasive or in situ. Definitely in situ disease carries a favorable prognosis and more better prognosis than being invasive. But here sometimes we see مثلا cases of DCIS and metastasized or carry aggressive behavior. This is because from the beginning there will be missing of an infiltrative foci in the primary tumor, or sometimes inadequate التايب الوحيد of in situ carcinoma هو الكوميدوكارسينوما اللي يكون عنده tendency for lymph node metastasis even if there is no invasive foci by the histopathological examination. Tumor size مثلا هنا ال second most important prognostic factor هو tumor size. Definitely there is strong relationship between tumor size and lymph node metastasis, tumor size and distant metastasis. So tumor size will affect the stage of the tumor, and small size is better prognosis than a large size tumor. Histological subtypes. هنا عندنا هذه التايبس of breast cancer يسموها favorable types اللي هي tubular carcinoma, mucinous carcinoma, medullary, lobular and papillary types of carcinoma. They carry better prognosis than none otherwise specified and than inflammatory type carcinoma. Distant metastasis. Definitely distant metastasis carries worse prognosis because it gives high stage of the tumor. The favored sites for metastasis of breast carcinoma includes lung, bones, liver, adrenals, brain and meninges. Why these sites? This is called organ tropism, and organ tropism is related to the expression of adhesion molecules by the tumor cells, and their ligands are expressed on endothelium of the target فيروح على هاي الأورجان. هذه نقطة. النقطة الثانية هي الكيموكين. أكو فد يعني presence of chemokine and their receptors in specific sites makes the breast cancer goes or choose a certain organ. Now skin invasion, definitely skin invasion. We put these tumors with the skin invasion or skin ulceration in stage T4 regardless the size. Also inflammatory carcinoma including under this condition. Lymphovascular invasion. Sometimes when we examine the tumor microscopically, we see a lymphatic vessel or blood vessel which is involved to contain a cluster of malignant cells. Presence of this malignant cells within a lymphatic vessel or blood vessel microscopically makes the prognosis poor. Paget disease of the nipple does not affect the prognosis, is of no prognostic relevance, but it can make the prognosis better because, as you mentioned, it brings the patient early because there is a clinical crusted nipple and erythematous nipple, so it makes the diagnosis earlier. Tumor grade, definitely tumor grade 1 is of favorable prognosis, 2 moderate prognosis, and 3 of bad prognostic value. Lymph node metastasis. Lymph node metastasis, here we talk about the clinical lymph nodes involvement is not accurate and it can give false positive, which means that large lymph node regarded as metastatic, and false negative, which means that a small lymph node can contain metastatic deposits, but it's regarded as negative because it is a small size. Therefore, biopsy is necessary for accurate diagnosis and assessment. Here, a 10-year survival for a patient with no lymph nodes involvement is about 70 to 80%, and if there is 1 to 3 lymph nodes involvement or metastasis, the survival will fall to 35 to 40%, and the survival 10-year survival is 10 to 15% if more than 10 positive lymph nodes. The most breast carcinoma drain to 1 or 2 sentinel lymph nodes. Sentinel lymph node here, first node that is involved by carcinoma, and this is important and can give a predictive for the status of the remaining lymph nodes. Breast cancer gene. Early studies suggested that patients with breast cancer one gene mutation associated with worse overall prognosis. Estrogen progesterone receptors, definitely this affects the prognosis and the treatment. Hormone receptors positive tumors carries better prognosis, and hormone receptor negative prognosis carries less favorable prognosis. HER2 receptors, overexpression of HER2 carries poor prognosis. Proliferative rate, we have many methods for proliferative rate counting of rate of proliferation of malignant cells. Here we have flow cytometry, S-phase fraction. We have mitotic counts. من الميتوتيك count أقدر أعرف إذا هو rapidly dividing. أكيد كل ما كانت high mitosis كل ما كان rapidly proliferating tumor. Or by immunohistochemical studies. بالimmunohistochemistry نعرف عن طريق السايكلين والكاي 67 ينطينا hint عن proliferative rate. DNA content, the amount of DNA per tumor cell can be determined by flow cytometric analysis or by image analysis of the tissue sections. With aneuploid tumors carries abnormal DNA carries slightly worse prognosis according to certain studies. Thank you.